So, today, 18th of June 2015, this is the final defense of the student Patrick Dunn. The committee members are Dr. Anderson and Dr. Margaritis. The title of the dissertation is Understanding Health Literacy Skills of Patients with Cardiovascular Disease and Diabetes. So, dear Pat, first you will present your dissertation and then we will vote asking some questions if you passed or not. Also, please remember that this defense is recorded. So, you may start now, and please always mention the number of the slides you are presenting.
Okay. Great, thank you. So I'll begin with slide number 1. Hi, and thank you for giving me the opportunity to present my oral defense of my presentation, or my dissertation, Understanding Health Literacy Skills of Patients with Cardiovascular Disease and Diabetes. On slide 2, I would especially like to thank Dr. Margaritis for being my chair, and also for Dr. Anderson for being my committee member. I really do appreciate both of you through this process. Moving to slide 3. So a little bit of background on health literacy. First, I have worked in the field of cardiac rehabilitation as both a clinical exercise physiologist and a health educator for over 30 years now. And I now work for the American Heart Association, and I work on what's now called the Patients and Healthcare Innovation Team. So this work that I'm doing, I'm happy to say, will be able to apply directly to what I do in my professional career. Health literacy has always been of interest to me. Health literacy is described as the ability to understand information needed to manage health. Based on data from the National Assessment of Adult Literacy, it's estimated that 90 million Americans have below basic health literacy skills. And of course, this is not just an issue in the United States, this is also a global issue. Low health literacy is linked to poor health outcomes. And with the publication of Health Literacy, A Prescription to End Confusion by the Institute of Medicine, health literacy is a public health priority. And finally, with the growth of the internet, patients are increasingly using digital tools and mobile devices to manage their health. Moving to slide 4. The National Action Plan to Improve Health Literacy has set a goal of creating a more health literate society. The common strategies include the use of plain language, avoiding jargon, with clear and concise messaging, and the use of techniques such as the teach-back method. These strategies are designed to ensure understanding, but not necessarily to build new skills. This is why it's always confounded me and why I'm interested in health literacy, really from an educational perspective. So a patient recently diagnosed with cardiovascular disease or diabetes may lack the knowledge and skills to manage their condition and does not necessarily have a personal experience to draw from. While these strategies are effective, especially in communicating with people with low literacy skills, the action plan also aims to increase health literacy, become a more health literate society, implying that they envision upward movement in health literacy skills. Also in the National Action Plan, there is a goal of increasing basic research in the development, implementation, and evaluation of practices and interventions to improve health literacy. Slide 5. The purpose of this study, therefore, is to gain perspectives from patients and healthcare professionals in the development of health literacy skills in patients with a new diagnosis of cardiovascular disease or diabetes, and to gain perspectives on the use of digital tools and mobile technology in the development of health literacy skills. The impact of this issue is a better understanding of how health literacy skills are developed, leading to better health strategies and interventions. The social impact of this issue is better outcomes for patients to manage their condition, leading to better health. The gaps identified are that the majority of research on instructional strategies to improve health literacy has been done in children and adolescents. The results of studies of health literacy instructional strategies in the literature are mixed. And while digital tools and technology shows promise as a method for improving health literacy skills, these results are also mixed. And there is a gap in the understanding of how new skills are developed in adults recently diagnosed with cardiovascular disease and diabetes. These insights are necessary to developing strategies and interventions designed to build these skills. Slide 6. The research questions are, what are the perspectives of patients and healthcare professionals in the development of health literacy skills in patients that have been recently diagnosed with coronary artery disease, heart failure, hypertension, a lipoprotein disorder, or diabetes? Question 2, what are the perspectives of patients and healthcare professionals in the use of new technologies to build health literacy skills? Question 3, how do healthcare professionals and health educators assess and build health literacy skills in their patients? And number 4, how are instructional strategies designed to build knowledge and health literacy used by healthcare professionals aligned with the process of learning described by the patient? Slide 7. The theoretical framework is the social ecological model. This is a multi-level model that is derived from multiple sources. The social ecological model includes individual factors as well as social, environmental, and population-based factors. This is in line with the Institute of Medicine report that health literacy is a product of individual, social, and environmental factors. The social ecological model can be applied to health behaviors and is recommended by the American Heart Association for the dissemination of health information. It applies to health literacy because patients are exposed to health information on multiple levels, including healthcare professionals, digital and print media. Other behavior change models and conceptual models are in the health literacy literature, but none of them describe how new skills are developed.
Everybody needs to take 5
Slide 8. This research was a qualitative study. This method allows the researchers to gain perspectives of patients and healthcare professionals in the development of health literacy skills. The selected research approach is grounded theory using the methodology described by Corbin and Strauss. Interviews were conducted on patients that had been diagnosed with cardiovascular disease or diabetes within the past 12 months, and healthcare professionals that care for or educate these patients. The cooperating sites and sources of study participants include 2 medical practices, patient-centered programs provided by the American Heart Association, and social media sites. One of the medical practices was a primary care practice, and the other was a cardiology practice. The American Heart Association also provides patient-focused resources and programs. And finally, I created social media sites on Twitter and Facebook and had access to social media sites provided by the American Heart Association. Healthcare professionals came from the 2 medical practices and health educators that work with these patient-centered programs. Slide 9. 16 patients were interviewed, including 6 males and 10 females. The average age was 55.4 years, and the ages ranged from 33 to 79. All of the patients had at least a high school education, and 7 of the 16 were college graduates. 7 were recruited from the 2 medical groups, 8 were recruited from the American Heart Association program, and 1 directly from a social media site. Many of the patients had more than one condition, so on the right, under the type category, the numbers add up to more than 16 because some patients had, a heart attack and diabetes, for example. And as you can see, they represented a broad and balanced range of heart disease and diabetes conditions. Slide 10. 19 healthcare professionals were interviewed, including 5 males and 14 females. The average age was 50.4 years, with a range of 26 to 82. This group represented also 24.4 years of professional experience. The healthcare professionals also represented a broad range, including 5 physicians. Of those physicians, 3 were cardiologists, 1 was a family practitioner, and 1 was an emergency room physician. Also 5 nurses, and they ranged from critical care nurses to patient educators. a nurse practitioner, a physician assistant, a pharmacist, a dietitian, a social worker, and a medical assistant. I was also able to interview 4 non-licensed professionals that were health educators, a health coach, and even a designer of print and digital educational resources. Slide 11. There were 3 levels to the coding and analysis. The first level was open coding. The second level was axial coding, which is a method linking the codes and is described by Corbin and Strauss. This is an intermediate step in the theory development. Some grounded theory methods, such as the one described by Kathy Charmas, has eliminated this step entirely. But staying with the methodology of Corbin and Strauss, I did use this step. And the final level was theory development, which is based on both the open and axial coding and the memos that I wrote throughout the data collection. And they were used to create a theoretical explanation of the process and actions related to the core phenomena of developing health literacy skills. Slide 12. The original coded segments were categorized by both patients and healthcare professionals. A total of 566 segments were coded, and they included 70 codes and 8 categories. The most common code was related to resources and technology, followed by teaching methods and emotions. The themes were not just based on the number of responses, however, but by how they related to the research questions, really the depth of the response, and the theoretical explanation. Slide 13. The first research question was, what are the perspectives of patients and healthcare professionals in the development of health literacy skills in patients that have been recently diagnosed with coronary artery disease, heart failure, hypertension, a lipoprotein disorder, or diabetes? The key theme is that social support is a learning opportunity. Patients talk about their emotions, and professionals talk about the need to address the emotional state. Comments included, if they are overwhelmed, they are not learning, and the heart attack scared the bleep out of me. When patients and professionals were asked about the process of learning, they talked about the behavioral approach, including the levels of motivation and self-efficacy. This approach involves taking the information into action by changing a behavior, such as an eating pattern or beginning an exercise program. Both groups recognized how important this was in setting the stage for learning. While I had perceived this to be parallel to, but not part of the learning process, the insights from both groups indicated that this actually was part of the process. They also mentioned programs such as cardiac rehab, diabetes, weight loss classes, and online support as keys to developing their health literacy skills. Several patients mentioned the program they were participating in as being important in reducing their anxiety, giving them more confidence, and that it provided a social support network. The theme that ran through all 3 of these categories was the need for a support system. The support system was used to manage their emotions, their behaviors, and their ability to learn. Slide 14. So while social support is used extensively in other conditions, such as cancer, it is really not used that much in cardiovascular disease. There are, however, some examples in the literature, such as the Lifestyle Heart Trial and the Stanford Coronary Risk Intervention Project. Both of these, ironically, were published back in the 1990s. Both of these included support groups as part of a multifaceted intervention. So it didn't necessarily tease out the impact or the independent role of social support, but they clearly identified that as an important aspect of the program. Several conceptual models were mentioned in the interviews. Patients described a self-directed, iterative approach to learning using their own conditions, which is really consistent with adult learning theory. And when they lacked direct experience, they really they drew upon the experiences of others. Professionals mentioned both Maslow's hierarchy of needs and the Kubler-Ross stages of loss, or stages of high emotions and a focus on intermediate needs. And effective learning only occurred at the later stages in the process. Slide 15. So this is an illustration I created trying to explain, since I wasn't clear on that before the data collection, of how the social and emotional support could be related directly to the development of health literacy skills. First, social support reduced the anxiety level to the point that the patient was better able to process the information. Patients and professionals alike stated that the best way to resolve their anxiety was to become connected to a support system. Sharing experiences also appeared to be a way to build a base of experience. So again, since they didn't have their own experience, they wanted to learn from others, and they almost incorporated, the insights from others as though it were their own experience. So basically, the experience, really was used in place of having their own personal experience. And then finally, the support system itself became an instructional platform, allowing for a high level of personalization. In the case of physical programs like cardiac rehab, the instruction then occurred both formally through educational classes and informally through conversations with the doctors and nurses. In the case of online support, a lot of the education came through links and references as other sources of information. Slide 16. Research question number 2, what are the perspectives of patients and healthcare professionals in the use of new technologies to build health literacy skills? The theme here is Google is a health system. The majority of information came from unaided, self-directed internet searches. These independent searches are used to fill in the gaps in their knowledge and experience. Patients prefer going to trusted sources such as WebMD, but other than recognizing the name, they really have no way of knowing if the information is accurate. Professionals see themselves as the trusted sources of information, which for the most part is true, but patients not only use the professional to validate the information they get from the internet, they also flip it around. They use the internet to validate the information they're getting from their healthcare professionals. So while many of the patients use digital tools, it is unclear how these tools were used to manage their conditions. From the perspective of the patient, they are really tools and really don't take the place of direct communication with their professionals, educators, caregivers, or even other patients. The most common tool, other than the internet, was a blood pressure unit. Of course, patients with diabetes also use glucometers, in a similar manner. The use of wearables, such as a Fitbit and apps, were actually very limited. From the perspective of the professionals, while many see these tools as the future, others see them as barriers to communication with the patient. There also is a gap from the perspective of the professionals because the designers and developers of educational materials actually have very little direct contact with the scientists, the clinicians, and the patients. Also, there was considerable confusion about what digital tools even meant, and many of the patients really struggled in how to use the technology and certainly how to apply the technology to their health. Slide 17. While the use of digital tools in chronic disease is increasing, it is not clear from this study how these tools were actually used. Many of the patients downloaded apps and purchased wearables only to find that they didn't use them or they couldn't get them to work. The healthcare professionals see the use of digital tools as the future, primarily because they don't have the time or resources themselves. Some of the professionals also see digital tools as a barrier to communication because the patient is exposed to information from external sources, which may create confusion, be contradictory, or flat out wrong. The primary use, however, was in seeking information and viewing videos. Also, many of the patients would experiment with different strategies to control, say, their blood pressure or blood sugar. For example, they would try different foods and see how it would affect their numbers. And many of them actually knew how a certain food would impact, say, their blood sugar or even their blood pressure. Slide 18, research question 3. How do healthcare healthcare professionals and health educators assess and build health literacy skills in their patients. The key theme here was instructional strategy should be personalized, interactive, social, and relevant. The traits of strategies that were perceived to be effective at building health literacy skills included being personalized, interactive, social, and relevant. Basically, if the patients did not connect with the information, content, or approach, they really didn't stick with it, and it had very little impact. Patients attempted to integrate the information they received from their own experiences, and it had to be relevant to them. The greatest influence on the patient was the physician, but that does not mean that they blindly follow the direction of their physician. More on this really in the next research question, but suffice it to say, while the information from the professional was important, it was not the final word. Most patients preferred a multimedia approach, meaning they received information from multiple sources. For example, they would have a face-to-face encounter with the doctor or the nurse, and then follow up with a video. In general, the patients wanted more information than what they were getting from the healthcare professionals. Slide 19. The majority of healthcare professionals had little or no formal training in educational methods in general or anything specific to health literacy. In fact, only one, a former English teacher, had any training in educational methods. Several of the healthcare professionals expressed frustration at the system that is not designed to provide or is willing to compensate for patient education. None of the healthcare professionals assess the health literacy of their patients, and they assume the patient's health literacy from their verbal skills, the types of questions they ask, and their educational level. Health literacy development is based on the achievement of clinical goals, such as achieving blood pressure, glucose, or weight goals. In other words, if the numbers improved, the perception was that the skills were being developed. Several of the strategies were in line with Teach to Goal, which is a method for building health literacy skills, which breaks down the message into smaller chunks of information. From the patient's perspective, however, there was a desire to gain more information and not have that information filtered by their healthcare provider. Slide 20. Research question 4. How are the instructional strategies designed to build knowledge and health literacy used by healthcare professionals aligned with the process of learning described by the patient? The key theme here, patients are self-directed learners. I'm not sure that this question was really answered. I think I've only really scratched the surface on this, and it would require a separate study to really gain more specific insights. It did, however, identify areas that might require more exploration. For the most part, strategies by the healthcare professionals were in line with the learning needs of the patients. There was a healthy and sometimes not so healthy distrust of the information they received from the healthcare provider. Several of the patients felt like they had been misdiagnosed previously and needed to validate the information they were getting from their healthcare provider. These strategies employed by both the patients and the healthcare professionals were based on a motivated and self-directed learner, and there does not appear to be much to offer to the unmotivated patient. Slide 21. Of the two most common strategies for health literacy, the teach-back method and using plain language with clear and concise messaging, there was mention of these strategies among the doctors and nurses, but not at all among the educators. The takeaway for me was that while health literacy is certainly a public health issue, many of these issues are really the result of how the information is presented and disseminated to the patient in the first place. I was also surprised to learn, actually, that adult learning theory, in which self-directed experiential learning were keys, was actually a pretty good theoretical framework for this. Slide 22. The next step in the coding process was axial coding, in which the categories were linked. According to Corbin and Strauss, much of the theory development occurs where these categories come together. This process was used to categorize each of the areas as a causal condition, phenomena, strategy, context, intervening condition, or consequence. The causal conditions were the patient's population, since the diagnosis was the what initiated the process in the first place, and of course the behaviors and risk factors that led to these causal conditions. The phenomena is the development of knowledge and skills. The context was the support system, access to resources and technology, and the instructional format. Intervening conditions included the emotional state, the influencers, the behavioral approach, as well as the initial level of knowledge and skills related to the conditions. The strategies included the support system, programs and interventions, and the traits of the tools, programs, or interventions. And finally, the consequences included a healthy distress, being self-directed, having a personal experience, technology confusion and the digital divide, confidence and reduced anxiety, and of course also led to the development of knowledge and skills, the modification of risk for poor health outcomes, and ultimately the quality of their lives. Slide 23. This all led to the development of a theoretical explanation of how health literacy skills are developed. This process began with a new diagnosis. In the model, the first step is an assessment of the emotional state and emotional support of the patient. If it is not good, due to anxiety, depression, or denial, the emotional state is addressed. In some cases, it was addressed by the doctor with medical management. In other cases, a support group was used to facilitate emotional support. Once the emotional support was addressed, the next step was the initiation of a behavioral approach. Motivation, self-efficacy, and self-directedness were key drivers. If the behavioral approach was lacking, again, social and emotional support was used to build motivation and confidence. Once the emotional support and behavioral approach were addressed, then an instructional strategy was initiated. Initiation of an instructional strategy without regard to the emotional state and behavioral approach was perceived by both patients and healthcare professionals to be ineffective. The instructional strategy also had a support system component that was either the strategy itself or it was complementary to the instructional strategy. The instructional strategy also had a component that was internal and provided by the healthcare professional, and an external component that leveraged technology. And the technology was dependent really upon the resources of both the patient and the professional. From the patient perspective, let's use P1 as an example. P1 was a 51-year-old female that had a heart attack last May. She described herself as an emotional mess and would basically call her doctor every other day with questions. She started attending cardiac rehab and was able to relax and begin to process what was happening. The structure of the program provided an approach that she could follow. And once she got into the program, she started attending group educational classes and was able to connect with staff and other patients. The program gave her confidence to begin exercising at home, and she started reading books on nutrition. She's now a patient advocate to other patients through cardiac rehab and through the support network. From the healthcare professional perspective, let's use HP1 as an example. He's a primary care physician with a busy practice. When he makes a diagnosis, he starts by addressing the emotional state of the patient, which may include medical management and a referral to a lifestyle change program conducted in his practice. The program provides a weekly group session that focuses on group sharing and motivation. He encourages the patients to use technology to track behaviors and biometrics. He does not assess self-literacy and bases their level of knowledge and skill on the types of questions they ask and whether their numbers are improving. And he's very frustrated by the time, lack of reimbursement, and lack of science-based tools that he can use in his clinical practice. Slide 24. A limitation of this study is that there was no measurement of health literacy. The population was intended to be a cross-section of patients, not just those with low literacy. The recruitment strategies may have attracted patients with a higher level of literacy, and may also have attracted healthcare professionals that were more aware of health literacy as a public health concern. All of of the participants were elite high school graduates and several were college graduates. Based strictly on their verbal skills, I would guess that probably 2 to 3 of these patients may have been classified as having below basic health literacy skills. Slide 25. The implications for social change include the role of social and emotional support in the development of health literacy skills. These insights may lead to the development of more effective tools, digital and otherwise, and programs, and the development of more effective instructional strategies for healthcare professionals. Also, these data indicate that there is a need for better options for the unmotivated, non-self-directed learners, leaving no patients behind. Slide 26. Recommendations for research include a better understanding of the role of social support in the development of health literacy skills and the role of different forms of social support, such as programs and online support. This might take the form of a mixed methods or even a quantitative study investigating how these systems and programs actually impact knowledge, literacy, and self-management skills. Recommendations for practice include the timing or format of instructional strategies, strategies at different levels of health literacy, and the role of digital tools. For example, discharge instructions using printed material provided in a single session at discharge when there are competing priorities may not be the ideal setting. Nurses all mentioned beginning the discharge instruction process earlier and using smaller bits of information and making it more interactive. Educators also mentioned, the importance of extending the conversation post-discharge. Slide 27. The benefits to patients may include better instructional strategies. The benefits to healthcare professionals may include better use of resources. These insights may benefit the developers of educational materials and digital tools. Dissemination includes better access to trusted digital tools, training of healthcare professionals in health literacy. And this can be done through conferences, journals, and including, not only medical journals and medical conferences, but also health tech sources as well. Slide 28. So I want to thank you, and this concludes my oral defense presentation, and I would like to invite your questions.
Congratulations, Patrick. Excellent job, as usual. Very good presentation, and you work very hard, very timely, and you have a very good outcome. Congratulations again.
Thank you.
So, Dr. Anderson, if you want to ask anything to Patrick.
Absolutely. Patrick, this was one of the most outstanding presentations I have seen in a long, long time. It's outstanding. Dr. Margaritas, I think a lot of the success is due to your good direction also. So Patrick, I have a couple questions for you. What was one of the pieces that most surprised you about the research? What finding most surprised you?
Yeah, the main finding was the most surprising. If I go back to, my entire premise was that I thought instructional strategies were lacking because they actually lacked an emphasis on instruction. And what I really found, and actually when I went back through the literature, even in proofreading the documents, I recognized that there were references to social support and emotional support and all of that. But so the major surprise and what really has, I think, grown my understanding of health literacy is how important that really is. So I would say that's the main surprise.
Yeah, I did some research for the NCQA a few years ago on a project on tobacco, and tobacco is not an interest of mine at all. But anyway, one of the primary ways that they found to have people quit smoking was a social network that didn't smoke. It was the number one reason. So yeah, I hear you on that. Okay, then my second question is, this is awesome information. So where do you plan to publish?
Yeah, that's a great question also. So, my I'm literally sitting here in a conference center at the American Heart Association. One of my goals, the scientists and researchers that we work closely with have a very strong emphasis on quantitative studies. They do a lot of registries, a lot of clinical trials, a lot of basic science. I actually work very closely with science colleagues and quality colleagues, and over the past year, I've really been trying to increase their awareness of qualitative research as complementary to quantitative research. Now, and ironically, as I was doing my lit review, the editor of Circulation, which is our primary journal, actually wrote an editorial on the need for more qualitative and mixed methods research, especially in areas where not a lot is known. And I would kind of put health literacy into that category, at least the building of health literacy skills. So getting to your question, I would love to present at an AHA conference, like our scientific sessions, and to publish in one of our journals. I was thinking a journal like the Journal of the American Heart Association, which is actually, it's an online journal. Beyond that, just going back through my lit review, patient education and counseling seemed to be a journal that I referenced quite a bit. There were a couple of other, open access journals that seem to have a lot in this area. But to be honest with you, that really does kind of need to be my next step, is to figure out where to publish this.
And you know that when you publish your information from your dissertation, Dr. Margaritas and I are your co-authors.
Absolutely.
Of course.
Yeah.
Do you have suggestions yourself on?
I think you have I think you have a good line on where it belongs, definitely. I was most impressed, and so whatever journal that you pick, I was most impressed with how you used grounded theory and that you came up with a model. So, you probably can publish this in multiple sources, slicing and dicing it a bit differently, but really concentrating on one of them, on grounded theory approaches to health literacy, because your model is so good. It's new, it's innovative, it's different. So, you probably have 4 or 5 different publishable studies within your dissertation, if you think about it. But I'm really impressed with that. And your graphics, just outstanding. So then I have a personal question. Right now I'm teaching a qualitative research class for Walden 8300, and I was wondering if I can share your presentation with that class.
Absolutely.
Great. I will. Because it's recorded. It'll probably be up to be listened to in the next couple of days, and they have the PowerPoints to listen to. That would be very helpful for several of them.
Sure.
So those are my only questions. Thank you so much for the outstanding job.
Related to that question too, I actually work part-time now in the Academic Skills Center at Walden. And I do, ironically, I do tutoring for biostatistics. But and actually I think it's helped because I still have my foot in the door on, quantitative methods as well as learning a qualitative method. But our Academic Skills Center has really stayed focused on quantitative, and qualitative is quite a different animal. So you couldn't expect a biostats tutor to help a student. But I do think that students in qualitative courses need resources just like the quantitative students do.
Yeah, it's the wicked stepchild in any school. So,
yeah.
Thank you, Dr. Anderson. And thank you for your help during this dissertation process. Thank you very much. So, Patrick, just about the publication issue, I also think that you must publish your work. Of course, I will help you, and we will talk about this because I want to publish this paper in a very good journal with impact factor, you know, because it will be very good for your academic career. So we will talk about this. We will make a list with some journals. We will discuss this, and then we will try to in each of them. Okay?
Yep. You know, on that point too, and related to the earlier question, and I think we've actually talked about this a little bit. You know, the definition of health literacy is a little bit different in the U.S. than it is in Europe.
Internationally. Yes.
I think in the U.S. there's more of an emphasis on the linguistic, you know, the reading and comprehension, and more of an emphasis in other parts of the world on more functional and critical literacy areas. So I wouldn't be opposed also to looking at even some international journals.
Yes. You know, all these journals that are very good, they have, regardless if they are in Europe or in United States, they also have an international section. So don't worry, we will talk about this because it's not only about your topic, but as Dr. Anderson said, it's about your methodology, the use of grounded theory. So it's a little bit complicated. Which editor will like what about your study? So as I have published a lot of papers and I know how difficult this is, but it's also very rewarding, and as I know that you want to follow an academic career, I think that it's worth to do our best to the best journal, and then we will see. Okay? Okay. I'm sure that Dr. Anderson will help us with the paper and all this. We will work about this together. Don't worry, Patrick. So, I also have, I know that you almost told about everything about your topic. You are an expert now, so it's very difficult to ask questions. So, I have a couple of, first, about slide 24, the limitations. You say that you may attract participants with higher health literacy and also healthcare professionals which are more aware of health literacy. As this is a qualitative study, why this is a limitation? Because remember, this is not a quantitative. You need a proposal sampling. Tell me how you see it as limitation for your study.
Well, limitation only to the extent that the individuals with low health literacy may not have been represented as well in the population. We did not specifically target in any way patients with low literacy, and the same with the professional. And because there, the voluntary nature of the recruitment, we couldn't, screen or poll or anything based on that, both on the patients and the professionals. So I think it was just an observation that, these patients, came to me based on the flyer, and, maybe a patient that had low skills may have not been as interested in sharing their insights.
Okay. So if you, for future research, you will try to target more with low health literacy skills, correct?
It's potentially. I intentionally wanted to have a large cross-section, not just, many of the studies in the literature, really focused on patients with low skills. And I intentionally didn't want to only focus on patients with low skills, but there could be future studies, where, patients with low literacy skills, are the focus of the study.
Okay. So, just to remind you that we will not in a qualitative side to have a representative sample of the population, neither all this stuff. Just we need persons that they want to talk about this and they have something to say. And that's why we want to make the theory. And this is my second question. How do you feel as you conducted the interviews? Did you see that they have to share things about their experiences? It was easy for you to take the information you want. How do you feel?
Yeah, I had to make sure that I was staying on script, and that I wasn't, trying to lead the patients. I really tried to focus that. So I really tried to, let them do as much of the talking as possible. Early on, because there was such an emphasis on the emotions and the motivations, I really tried to emphasize and almost ask, a second time, I'm really focused on how you develop the knowledge and skills, not how you were motivated. And even with that, they would still talk about their emotions and their motivation. So I felt better about that. I felt, overall, I felt good about how their responses.
Okay, very nice. And which was the most difficult part in all this dissertation process, from the beginning to the end? As now you are almost a doctor now, you have a PhD. What do you think that it was the most difficult part during your dissertation research?
I found the whole process, you have to be patient and take it kind of one step at a time. I think probably the most challenging was getting through the IRB, just, making sure that you had things exactly, the way they needed to be for the IRB, which I know those things are in place for a reason. But that was probably the biggest challenge, was just that process. And because in grounded theory, at least, the early versions of grounded theory, you kind of, you kind of go with where the, where the patient or where the subjects are taking you. And, with the IRB, that's a little bit more challenging to do. So, but, obviously I had to stay within the confines of the IRB for that.
And you learned a lot, I think, about this process.
Yeah, absolutely.
Okay. So, and my final comment, as I also work, as you know, with both quantitative and qualitative data, and how do you feel? Are you feel that now you want to work with both data in the future? Because, as you know, it's very significant for public health to work with mixed methods research.
Yeah.
So, do you want to continue to work with both data?
Yeah, I do. Like I said, I do the biostat, tutoring, and so I feel like I'm learning in both methods. And I do, I would like to do both, actually.
Okay. This is great because, and I also can give you some guidance on this because even professionally, if you see it, it's very few people and very few researchers in the world work with both qualitative and quantitative data. So if you focus on this, it will be very useful for you.
Yep.
Okay. So I'm also done. So Dr. Anderson, do you have anything else to add before we vote?
Nope, I'm good.
Okay. So Dr. Anderson, do you accept this dissertation?
I do. I vote to pass Patrick on to completion.
I also agree. Congratulations, Patrick. You are finished from us. Congratulations. And this is a great step for graduation, and I wish you the best for your future.
Thank you very much. I appreciate
How are you feeling now?
Relieved.
I know. So, because this is a major step, and I know that maybe sometimes your family or all families do not understand how hard work was about this. I want you to celebrate this with your family, maybe not today, in the weekend, to understand how significant it was.
Yep. Thank you.
Okay. Okay. So we will be in touch on the next steps, and Dr. Anderson, we will talk about the qualitative, our final review that it will be submitted. I will contact you about this. Okay, Dr. Anderson?
All right, that sounds good.
Okay. Thank you both. Congratulations again, Patrick.
Yep.
And we will be in touch soon. Okay?
Congratulations, Patrick.
Thank you. Yep.
Okay. Bye-bye.
Bye.
Bye-bye.
Bye.